Here we go with lesson 4 on oxygenation and hypoxia. That's part of the fundamentals unit. We've talked about circulation, ventilation, oxygenation. Before that, we talked about keeping yourself safe. And so in this one, we're going to move on with oxygenation and hypoxia. This one is shorter. It's a key concept, but it's not real complex. And so half an hour or so of online prep should do it. And then we can do some stuff in lab to really reinforce that. And it all will tie together very nicely with circulation, ventilation, and oxygenation. So in this lesson specifically, we're going to talk about the A and P on oxygenation. Going to define hypoxia, how to assess it, how to treat it, and how we're going to assess and manage oxygenation. Oxygenation is defined as the O2 transferred into the bloodstream at the alveoli and then transferred out of the bloodstream at the tissues. Basic concept. Good air comes in, it has oxygen in it, gets moved into the bloodstream and carried out to the cells, and then it comes out of the bloodstream and into the cells. Oxygenation. We have circulation, we have ventilation, and we have oxygenation, CVO. Remember, the ventilation brings the O2 into the alveoli, the tiny air sacs in the lungs, the microscopic air sacs in the lungs, and we have a bajillion of them. The ventilation brings that fresh air in that has oxygen in it. The oxygenation piece is when the O2 climbs out of that air into the blood, and the circulation delivers it out to the cells. Good air in, bad air out, blood goes round and round. Basic stuff. One of the ways we can assess oxygenation is through the use of pulse oximetry, a pulse oximeter. The pulse oximeter is a device that clips on a finger and looks through the nail bed or just looks through the skin. It doesn't have to be on a nail bed, but typically we put it on a finger looking through the nail bed, and it measures the saturation in the blood. It measures how red a red blood cell looks when it goes by the pulse oximeter. The pulse ox the machine doesn't know anything about oxygen levels or carbon monoxide levels. All it knows is how red a blood cell looks when it goes by. And so it counts how red it is. It counts the extremely red ones, and then the kind of red ones, and the not really red ones, and it adds up a score and says, oh, there's 99% of the red blood cells that went by here when I was watching were extremely red. Or 84% were extremely red. So that's called the saturation. And so a pulse oximetry measures O2 saturation, not stat, sat, S-A-T. But pulse oxes are not infallible. How can they be fooled? Well, if there's really poor signal in that the finger's moving around and the machine can't really get a good steady look at the blood cells going by, it can't do its thing. If there's not many blood cells going by because the pressure in the finger is really low, then it's not going to give you an accurate number. And then the other thing is that pulse oxes measure shades of red, and carbon monoxide looks really red in the blood. And so since the pulse ox is measuring how red a blood cell is, a red blood cell is, and how many really red blood cells go by in a certain amount of time, if CO, carbon monoxide, makes that red blood cell red, then the pulse ox counts it. So a guy could have a very high CO level, and it would show as a high saturation on pulse oximetry. And actually, he's really low on oxygen, but the poor pulse ox can't tell the difference. Just to be clear, we've been talking about carbon monoxide here. That is a product of incomplete combustion. Whether that's coming out of the tailpipe of a car, or whether that's leaking out of a furnace into a house, or whether that's as one of the many, many bad things that are in smoke from a fire, that's carbon monoxide. We want to differentiate that between carbon dioxide, CO2, which is produced in the blood, or in the body, CO2 is produced in the body during metabolism. So as your cells make energy, They use glucose and oxygen to make energy, and they give off CO2, carbon dioxide. These are two entirely different things. Pulse oximeters don't have any impact from CO2. They don't measure it, and CO2 doesn't fool them. Carbon monoxide from an external source will fool your pulse ox and give you a falsely high reading. So here's some problems. Now, most of the time, this is not a big deal with pulse oximetry, although with other types of oximetry where you're putting a sensor on a finger, ambient light can be a problem. So if you're in a bright sunlight, sometimes you can have a pulse ox error. How do you deal with that? Just put your hand over the pulse ox or put a towel over it or something and just shield it from a bunch of ambient light. It's really not a big deal. Then we have, this whole thing about nails and nail polish. So fake nails can obstruct the view of the pulse ox. The pulse ox needs to see into the skin. Now, most nail polish won't fool it, but fake nails will fool it. But there's a lot of studies that show that nail polish doesn't fool, and that's widely misunderstood. There's a urban myth out there that you've got to be able to take the nail polish off of somebody's finger in order to do it, and that's just ridiculous. It's not been proven. In the olden days, when the first pulse oxes came out that the Pilgrims used, yeah, there was a problem, but not today. These advanced pulse oximeters are not impacted by nail polish. And if you're so worried about it, then don't have the pulse ox sensor look through the nail polish. Turn it sideways and let it just look through the skin. It's not a big deal. Patient movement more often is a problem, particularly with little patients that are kind of squirmy. And we have a hard time with the simple clip-on sensors to work there. And so some services, particularly ambulance services, will carry more of a Band-Aid type of sensor that really sticks on and adheres to the finger, as opposed to the finger just rests in it, like a lot of places use and many fire departments have. So why do you care about what their pulse ox is? Well, we're trying to measure oxygenation. And one of the ways we're going to treat oxygenation is with additional oxygen. Yes, ventilation is important. Yes, circulation is important. And oxygenation is important. And so we're going to deal with low oxygenation levels by giving them supplemental oxygen. Our goal is to have their O2 saturation, their pulse oximetry reading, be between 94 and 99%. We're not trying to score 100% on this. 100% is not a good thing. So we're looking for 94 to 99. And so if your patient's oxygen saturation is in the low 90s, but not quite to 94, some low flow oxygen, a low concentration of oxygen with a nasal cannula would be appropriate. If your patient's oxygen saturation is not even 90 something or above, we may need to use a higher concentration, more high flow device called a non-rebreather mask, an NRBM, a non-rebreather mask, a face mask with a reservoir that will allow us to give much higher concentrations of oxygen than you're going to get with just a nasal cannula. When you put the nasal cannula in somebody's nose, they're inhaling oxygen coming out of the cannula as well as room air, and so it kind of dilutes down the oxygen percentage that they're getting. But the non-rebreather mask pretty much eliminates the room air problem, so they're getting oxygen, pretty much straight oxygen, and that would be used when you've got a pulse oximetry reading, an oxygen saturation that's not even up to 90. But wait, that's too easy. Sometimes a patient with severe lung disease, emphysema, one of the chronic obstructive pulmonary diseases, COPD, or lung cancer, or some other serious lung disease, if they have serious lung disease, their normal pulse oximetry reading won't get to 94 to 99. Their normal oxygen saturation may be down around 90. And so we need to adjust our expectations for them down a little bit. Some of these emphysema patients sit at 88, 89, 90% on a good day. So if we go by this silly, simplistic formula that says, oh my God, he's not at 90, he's at 88%, he must get a non-rebreather mask. That's bad medicine, and we're smarter than that. It's not what our medical director wants. It's not what most standard protocols have, and so we shouldn't be doing that. In the absence of lung disease, a guy at 88% gets a non-rebreather mask. But in the presence of lung disease, let's adjust that normal down a little bit, maybe 5%. So if the normal range is 94 to 99 for a normal patient without lung disease, then let's get it down to that 89 to 94 is the normal for the lung disease patient. So a nasal cannula will be appropriate for the guy that's at 90 or 91% but has severe lung disease. A nasal cannula would probably be appropriate for 2 to 3 liters for 2 to 3 minutes right off the bat with most people that are in the upper 80s and low 90s with lung disease. Because really the rule of thumb, 2 or 3 liters for 2 or 3 minutes ought to get you 2 or 3 points increase on the oxygen saturation. And if it doesn't, then you may have a ventilation problem or a circulation problem. And so it's reasonable to start with that. Start with a couple of liters for a couple of minutes and see if you get some improvement. And if you don't, then you can switch to the non-rebreather mask. But it makes absolutely no sense, and it's not good medicine, to put a non-rebreather mask on somebody just because they're at 88 or 89% if they have lung disease. If they don't, yes, they should get big high flow. So we'll work on that in lab. And there's various different departments have different protocols, and you may hear different things. Be careful who you're listening to and make sure you know where they got their information. And I can tell you for the fire district, what I just told you is what our medical director expects. Pulmonary anatomy I want to talk about briefly. If you'll think about this thing as the pulmonary tree. So think of an upside down tree. And I alluded to this in a previous lesson, but we really need to drill on it now. If you look at a tree, there is the trunk, then there are 2 or 3 main branches that come off, and then those branches branch into smaller branches and smaller branches and finally down to twigs, and at the end of the twigs are the leaves. So here we go. The trachea is the pulmonary tree's trunk. The trachea divides into 2 big limbs. Those are called bronchi. The right main stem bronchus and the left main stem bronchus. Together they're referred to as the bronchi, the main stem bronchi. They are the first major limbs that come off the trunk of the tree. And then those divide and divide and divide and divide, and I think in the lungs it's like 30 times they divide and get smaller and smaller and smaller and smaller and smaller. And finally down at the twigs, you have the bronchioles, the terminal bronchioles. And right at the end of the twigs are the leaves. The leaves are the alveoli. One of them is called an alveolus. More than one of them are called alveoli. Pulmonary tree and pulmonary anatomy. Great pictures in your book. Need to learn this, need to prep on this. You can have obstructions. You can definitely have obstructions. Obstructions in the pulmonary tree can happen in the bronchioles. And 3 different things can cause bronchial obstruction. So here's a list. This is for flashcard stuff. This is how you prep. You go over this and do reps on this until you can say at any time, oh yeah, I know the 3 causes of bronchial obstruction. It could be a mucus clog because there's mucus in the pulmonary tree. It's snot. There's snot from your nose all the way to your alveoli. And when the snot gets really thick, it can clog up in the bronchi. It can clog up in the bronchioles. So it could be a mucus clog that's causing the obstruction in the bronchioles. The bronchioles have muscular walls, soft tissue walls, and so those can get inflamed and irritated from infection or heat or allergens or smoke. And those can be inflamed and swollen, so you could have just a swelling of the walls of the bronchiole. So it might be plugged up with mucus, or it might be that the walls are closing in because those are inflamed and have swollen. And remember also that there are muscular walls in the bronchioles, and so maybe those muscles are constricting, and you have bronchial constriction. And sometimes more than one of these is in play. A lot of times, all three of these are in play in severe respiratory patients. They have thick, sticky mucus clogging things up. Their bronchial walls are upset and inflamed and swollen, and that narrows the passageway. And then there's a little bit of irritation to the bronchial wall, and those muscles constrict. So now you have three things in play. And at the EMT level, we really don't have many options, not many tools to deal with this. If you go deeper into medicine, particularly deeper into field medicine, you'll need to attack all three of these problems with three different tools. So bronchial obstruction, for now, know that there's three causes and be able to name those. You can also have problems in the alveoli. Maybe the wall of the alveolus is damaged. Lung disease. Smoking damages alveolar walls. Could also be that the alveolar walls are fine, but the alveoli itself, the air sac itself, is full of fluid. If that's infectious fluid, like in pneumonia, the alveoli are full of pus. That could also be pulmonary edema, edema meaning fluid. So fluid in the lungs, because your heart's not pumping off like it should, and fluid has backed up into your lungs, that's pulmonary edema, and the alveolus is full of fluid. Either way, if the alveolar wall is not intact, then good oxygenation is not going to be happening. If the alveolus is full of fluid or pus or blood, then the oxygenation is not going to happen because of that. So if we can get air through the airway, we can get air down through the pulmonary tree, through the twigs, the bronchioles, and into the alveoli, the leaves, and the alveoli are intact and not full of fluid, then we can have good air exchange from the outside all the way to the bloodstream, and oxygenation can occur. So lower airway assessment. How do we know if there's a lower airway assessment? Well, normal breathing is not loud. You can hear breathing with a stethoscope when you listen. So there should be some noise going on. If the bronchioles are completely obstructed or the alveoli are completely full, it's going to be quiet. So quiet is not the opposite of not noisy. Not noisy airway is a bad airway, and a totally silent airway, not good either. Wheezes are a high-pitched musical sound. It's a whistle. It's air moving through a narrowed space, causing a whistling sound. And wheezes sound like whistling. And you would hear that sometimes just being near the patient using your ear. Other times you would need a stethoscope to hear that. And we'll work on some of this in lab. Then the other sound you may get when you do a lower airway assessment with your stethoscope is crackles. And crackles sound like crackles. That's why they call them crackles. In the old days, they called them rales. And they spelled it R-A-L-E-S, and a lot of people called them rails. But now they've quit saying that, and crackles is a legit medical term now. And so you can say to another medical provider, in your handoff report to the paramedic, in your handoff report in the ER, you can say he has crackles in his left lower lung fields, and that's completely legit for you to use that term. So part of our airway assessment is auscultation, is listening with a stethoscope, and these are some of the things that we can hear. So in this lab, we're going to have you work on a nasal cannula and non-rebreather mask, how to work the O2 tank, how to put the regulator on the O2 tank for those places that are still stuck with that. We're blessed in the fire district to have our regulator already come attached to the O2 tank, but it's not always the case, and one of the silly national registry skills is how to attach an O2 tank regulator still. So apparently there's a lot of people out there that have two-piece things to work with, so we want to work on that. We want all of you to experience oxygen flow through a nasal cannula at various liter flows. We want all of you to experience placing a non-rebreather and having it placed on you and what it feels like. We want you to know what your customers are experiencing. We'll work on lung sounds, where, when, how, what you're trying to hear, and we'll work on using the pulse ox. So really, assessment of oxygenation is pretty straightforward, but there's some stuff there. There's some stuff you wouldn't normally know. It's not common sense. We want to work on that in the lab. The way that you get prepared for that is to understand what we're talking about that we've reviewed in all of this presentation. Do the assignment, look at the resource document, do the prep, pass the readiness check, and be ready to fully participate in lab when you get there. The end.